Good morning, good afternoon, and welcome everyone to today's webinar, Spiritual Care and Community Wellness, Results of a Mixed Methods Inquiry. I'm Andrew Andresco with Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenters by typing your questions into the questions pane of the control panel that's located at the side of your screen. You may send in your questions at any time during the presentation. We will collect these and hope to include them during a brief Q&A session at the end of today's presentation. With that, I'd like to introduce Chaba Salaji, Director of Transforming Chaplaincy.
Thank you, Andy. It's exciting to be here today as we are going to be talking about spiritual care and community wellness and how our work might transcend the walls of the hospital. So here with us are Kelsey and Paul. Kelsey White is a board-certified chaplain, assistant professor, and the chaplain faculty researcher in the Department of Patient Counseling at the College of Health Professions at Virginia Commonwealth University. And we have Paul Galshut, also a board-certified chaplain and research partner with Transforming Chaplaincy at Rush University. Thank you for being here today, and I will turn it over to you.
Thanks, Chaba. Great to have you guys here. Today we're going to talk through some results. This is kind of the first public release, if you will, of the findings from a mixed method study that Transforming Chaplaincy and researchers here at VCU have put together. This is about spiritual care and community wellness, and we're going to actually talk through what I mean by community wellness here in a moment. So just to get us started, a little bit of an overview of what I'm going to talk through today along with Paul. We're going to look at a little bit of literature and what led us to the study and ask the questions we did and explore chaplaincy in the way that we did. As well as discuss then the methodology, the findings, a high-level overview of the findings, then move into more of a discussion, both with regards to what exists in research and how we put that in conversation with our findings, as well as the implications that we may need to think through for professional chaplaincy. And as much as that then says discussion, we will actually move then to question and answers. And we hope that in that question and answer, you can, engage us with your thoughts and your perspectives, as we know we may not have gathered them all in this study. So let's dive in. I think what we most commonly think about these days when it comes to the need for community health or population health, as we'll talk about in a minute, is the conversation around hospitals' efforts to shift how they address health and well-being, to move rather from this acute response model to a more proactive and health maintenance-focused way of operating. Now, it is also frequently discussed that there are financial incentives, especially after the Affordable Care Act, for hospitals to invest more energy and money into their local communities. So think about the conversations we've had about reducing unnecessary hospital admissions or reducing readmissions, and how the Affordable Care Act and healthcare policy has really influenced hospitals and how they address those problems and those challenges that they face in their daily operations. Now, what researchers have pointed out to hospitals and health systems is that really, if you want to improve the health outcomes and change the utilization of hospitals and from an acute response to a more proactive response, that really means that there needs to be some addressing of the systemic disparities that exist within communities. And so hospitals then have shifted shifted into providing energy, money, and efforts to address what we often hear is called the social determinants of health. Now, sometimes in those conversations, there are mentions of religious organizations, but it's less often discussed than we, at least these days, in terms of the long history that religious organizations have had in promoting and engaging the community around health efforts. So if you went back and looked at the history of the hospital's development across the country, many hospitals were actually started with financial support from religious organizations, or religious organizations themselves started hospitals in order to help community members gain access to health and to healthcare services. If we zoom back into the more recent times, in the 1970s, Granger Westberg actually talks about in an article that he published in the Journal of Pastoral Care about the idea of a holistic health center, where doctors and nurses would be providing care within churches and religious organizations so that community members could gain access through an organization in which they trust the people there. That model actually he ended up setting up 6 holistic health centers across the country. And what they documented was a higher compliance rate, or more individuals more likely to utilize for preventative care than individuals who are using hospitals that are doctors and healthcare providers that came through health systems. And then if we look even later in the 20th century, there was a shift, right? So that there were efforts where chaplains really partnered with religious organizations and other community organizations to provide different types of services to help gain the trust of the community, but also to reach out to the community based on who they are and their knowledge of the community, where the chaplain really is this mediator between the community and the health system. I think as we get more to recent day, we could talk about how the chaplain has become more individually focused and more focused on providing health care and spiritual care within a hospital's walls. But all that to say is that religious organizations, chaplains, religious leaders, there has been this history of being engaged in the community and figuring out how to promote health and well-being, even though sometimes it appears to be kind of invisible in our conversations. But more recently, healthcare systems are now having to take some leadership on those efforts because of the financial incentives and because of the requirements by the larger policy and regulatory environment. So now, all that to say is that we developed a research question kind of guiding us in these efforts, but also because there had been a lot of casual conversations about chaplains' efforts and the ways in which chaplains are trying to impact these metrics that hospitals and health systems have been tasked to change: readmissions, utilization, right? All of these things that impact the financial bottom line of hospitals and health systems. There's a lot of conversation, again, like I said, about how chaplains are participating in those. And so we sought out to explore, how are chaplains integrated or leading community health and wellness initiatives? Specifically, we wanted to kind of gather some broad baseline data through a survey and then explore how those and what those look like in very detailed examples of chaplains' integration and leadership. To do this, we used an explanatory sequential mixed methods design, and I'm going to explain what that is just for those with a little less familiarity with research methods. So essentially, it's a mixed methods study where you're using both quantitative and qualitative data. I've got a figure here that can kind of help illustrate what I mean. So what you do in this type of mixed methods design is you first collect some quantitative data to kind of get a broad overview, and then you look at that data, which will then inform the qualitative aspect of data collection analysis. Perhaps what we see here, or what we did see here, informed the questions that we asked in a way in the qualitative data and how we analyze those moving forward. So this mixed methods approach really helps us kind of grab data from a large snapshot of chaplains, right? and then we can go more specifically to see if we can look at that data and understand it. And we put the results of both the quantitative and qualitative in conversation with one another. So as I said, the first phase was to do a survey of chaplains and chaplain managers. We did that by advertising the study through listservs of professional chaplains, as well as Transforming Chaplaincy's listserv. And then from that survey, we asked individuals to indicate if they were willing to participate in a follow-up interview. Those that were willing and who named a program that chaplains were actively involved in were scheduled or invited to schedule an interview. So those participants ended up being chaplains or chaplain managers who were involved in leading these community wellness programs. As I said, the survey data was collected through Qualtrics, and then we audio recorded the Zoom interviews and transcribed them with rev.com. So when we did the analysis, we first did that descriptive analysis of the chaplains and programs. So think of this as having two different samples, essentially. A sample of the chaplains, right? And then a sample of the programs. And what we were really focused on is these programs and how chaplains were involved in that. The transcripts, we used both the transcripts and the survey data to inductively categorize the programs. So we categorized the programs that people put in the surveys and that were discussed in the interviews according to the intervention type. What was being done by the chaplain or the health clinician or whoever was in charge of this program, what was actually being done. We also categorized these programs in terms of their targeted health need. Were they trying to address something physical? Were they trying to address some mental health, social or spiritual health aspect? And then we looked at the level of chaplain involvement. After we looked at the interview transcripts, we further categorized programs and went back to the quantitative data that we had in the survey and categorized these programs based on the social determinant of health for which they were focused. And we used the CDC's categorization to do that. And we're going to talk about in a little bit as to why we did that at that point. But essentially, what we saw is that chaplains, well, let me get to that in a minute, actually, because I don't want to get too far ahead. So here's some information just about the baseline survey content. So we asked the chaplains about their title, who employed them. We open-endedly asked about program information, the name of the programs, a description of the program, and the level of involvement. We also asked if the health system for which the chaplain worked operated a federally qualified community health center. We won't talk about those results here, but we will. Those will be available in the publication that's forthcoming. And then we asked them about their willingness to interview. For the chaplains who were interviewed, we asked them again to describe the program and to describe and give examples of the level of chaplain involvement. We also asked them about the perspective of hospital administrators and community members and how the program came to be. Now, what I want to draw your attention to is this kind of infographic on the right side of your screen. I'm going to try to point you to the parts of it. So we made sure in the survey to give everyone a thorough definition of population health because that's essentially what we're asking about. And we gave them this infographic to ensure that everybody was on the same page. So what is population health? Population health is the health outcomes of a defined group of people, including the distributions of such outcomes within a group. So efforts that are aimed to focus on population health are really those that are interventions that aim and measure, right, the impact on a health outcome. So perhaps it's preventative services use. They talk about culturally and linguistically appropriate care, promoting health behaviors, but they also say that they track population health metrics, okay? And so what we find, if I can go back to this slide, is that most of the chaplains were focused on actually social determinants and aspects of social inequities and characteristics and systemic issues within the community, rather than programs that they were specifically targeting a specific health outcome. So Kelsey, what do you mean by that? Well, let's look some at the results and maybe this will help. So we had 25 chaplains within our survey sample, and they reported on 71 programs. Of those 25 chaplains, 10 were interviewed. 44% of the sample worked for a health system, 44% of the sample worked for a hospital, and another 12% worked for another healthcare type setting. Most were in the South and Midwest, and a bulk of them did not work for a multi-state health system. When we look at the programs identified by the chaplains, 37 of the 71 programs, so half, were discussed by the 10 chaplains that we interviewed. So 10 chaplains reported on half of the programs that they discussed. Among those programs, chaplains led half of them, but they were actively involved in another half. And most of the initiatives were organized or designed at a local level and not national initiatives. So when we categorize the types of programs and what the chaplains were doing, so like what was the intervention that the program was focused on? The biggest proportion of the programs were really focused on health education. So educating different individuals and members of the community on healthy behaviors, or how to use the health system, or advanced care planning, different aspects of educating and approaching health, population health in that way, okay? There was also a large proportion of chaplains who described their community wellness programs as essentially a fancier way of integrating in the health system. And we'll give you some examples of these. But from moving from an inpatient responsive chaplain type of setting to a more like integrated outpatient community, all of these different efforts that the health system may be putting on, and that the chaplain was integrated in those in some way. Participants also talked about support groups and bereavement support that they provided to community. Then we've got some community social networks, and we could talk about, we'll talk about what that looks like in a minute. Chaplains were also involved in faith community nursing. And then in these last two categories, which one is called community needs assessment and the other is called other, as said there, chaplains are actually involved in doing needs assessments for their local communities. The other were some very innovative and very nuanced approaches that were impossible to categorize in these other types of interventions. And these look like they're from most common to least common. I couldn't put each of these in their own individual category, so they're all in other, but they all kind of stand for themselves in terms of the results. Now, when we talk about the social determinants of health, and we'll talk about in terms of measurable impact and what we heard from these chaplains in terms of what they're measuring, but in most of the cases, it wasn't specifically a health outcome. Chaplains were all their interventions, their program types, the ways in which they were involved, those programs were really focused on healthcare access and quality. That biggest percent, 61.4% of the 71 programs, that was how chaplains are involved. They're really focused on how individuals in the community are accessing healthcare and the quality of the services. The second big chunk, which made up about 37.3% of the sample, was program interventions and types that were focused on how people were dealing with health or addressing health or resources within their social and community context. Another big chunk. And then actually only one program, even though it's 1% here, was focused on the neighborhood and the built environment. And that's really about the neighborhood that surrounds hospitals and health systems and where people work and live, and how those types of aspects can impact health. I will also highlight that if we talk about the targeted health need of the programs in which the chaplains were involved, so all of these programs that I'm talking about are all the ones that chaplains indicated they were involved in, okay? The ones that chaplains were not involved in or may have named, we removed those. So this is all about ones that our chaplains are involved in. A small proportion of the programs were focused on mental health, okay? About 5.6%, as you can see there on the screen. Then another set of the programs, about 46.5%, were focused on physical health. And then the largest chunk was actually focused on social health. And I put the social isolation is the yellow bar, spiritual existential type of interventions, and the health need, the targeted health need, as the white bar. And then this smaller gray bar here at the top was those programs that seemed to be both spiritually and existentially focused, as well as focused on mental health. So chaplains really, the programs in which they're involved focused on more of the social health aspect of community health and well-being, and then, like I said, healthcare access and quality. So when we look at a higher level at these results, so I kind of gave you the general breakdown of characteristics of the programs they reported on. And then there are other ways in which we looked at the results, especially of the interviews. So when we talk about the interviews and the programs that the interview chaplains kind of shared more about, only 3 programs of those discussed and interviewed had measurable impact, had been measuring their impact, okay? So, and you see some names there, those are actually pseudonyms, they're not the actual chaplain name. 2 of them actually could talk about ED utilization, and one of them, a chaplain leading, actually had measurable impact with regards to loneliness and readmissions. But most of those that we impact talked how they wish they could measure the impact and how they assumed that there was some impact, whether it be in utilization, trust, reassurance rates. So there's all these different areas that they talked about that, like wish. So this is, again, why we talk about it as more of a social determinant approach to community wellness and health, rather than a direct population health type of avenue for being involved in the community, because we're not measuring, none of these programs were measuring specific health outcomes. And that's what population health is really targeted for. We, as you saw in the first bar graph I told you, there was kind of more common to least common approaches to being engaged in community wellness, and we will talk about those more in depth in the next few slides. We also kind of explored, like, what is it about chaplains that led chaplains to be engaged in these? So there was a wide range of rationale, both in terms of when we asked about the healthcare administrators, when we talked about the community perspective, when we talked about colleagues' perspective, and some of the general themes were the chaplain's ability to build trust with community members, their ability to collaborate interdisciplinarily, and that really led to some of the programs that were identified by participants as stronger versus less effective in their own perspectives. And chaplain's ability to foster kind of this safe environment for difficult conversations. And then finally, when we talk about, is it community health? And that kind of goes back to previous comments I made about, population health versus more focused on the kind of social determinants or systemic inequities that are pervasive in the community surrounding health systems. We also had this problem of there's probably 17% of the programs that were described were not named clearly or described so vaguely we couldn't quite capture what the respondent was talking about. And this is really about the survey, less so than the interviews, because in the interviews we could kind of pull that out of the chaplains. Not to mention, when we talk about the ways in which some health systems have innovatively albeit integrated chaplains and various outreach approaches of their health systems or community programs. Is that integration of chaplains in that way population health or community health, or is that just a natural part of a chaplain's role? So for example, if there was a support program for individuals who may have needed childcare because a parent or a guardian or employee of the institution needed to go to work or were hospitalized unexpectedly, and that program did spiritual distress screening and brought in a chaplain when that spiritual distress screening indicated that somebody was spiritually distressed, does that warrant being involved in community health? I don't know that it's explicitly that, but it's another avenue in which chaplains are finding ways to adapt their roles to be integrated to promote the health and wellness of communities, but wouldn't typically fall in the public health conversation of health promotion and population health. And in some of the interviews, it was evident that chaplains kind of struggled to describe the actual intervention or a targeted outcome. They could describe what they're doing and the importance of what they were doing, but to articulate it in such a way that it specifically said, we did this to improve this because of this, it was more challenging, and we kind of had to be teased out of those conversations. And we'll talk about the implications and what kind of considerations that led us to when we get into the discussion. I'm going to turn it over to Paul.
Thanks, Kelsey. Thanks for inviting me to be a part of this project with you and Kanya and Chaba and George, and for teeing this up. And so, yeah, friends, we're going to switch gears a little bit. As Kelsey said, this explanatory model started with the quantitative, and I think, I don't know if you'd agree, Kelsey, kind of when you start this process, it's sort of like, you put on the preschool art bib and you get into the finger painting, and it kind of is messy. So some of the fun that you're seeing, friends, as colleagues, is where it gets a little bit less messy. So as you can see, we're going to walk through the next slides and hear from the voices of our colleagues and how they offered us, as we say in the qualitative world, a rich description of what it was that they and are still perhaps doing in their settings. So as you can see, it's organized, and Kelsey had referred this to a little bit. It's more common, and less common. So the next few slides will do that. So maybe that aphorism, common approaches ain't so common. So maybe that applies here too. But let's jump on in. Think of that bar graph a little bit as we're kind of walking through these that Kelsey showed earlier. And I'm going to start with health education. And I'm going to actually probably read these to give you that better sense. So as Kelsey had mentioned, I just want to affirm, if you're joining us a little bit later, these are pseudonyms. These are not the real names of our colleagues. I just also want to add thanks to these colleagues for participating, because we don't have these data unless they offer that. We wanted to bring attention to unconscious bias, attention to disparities in health coverage, attention to how chronic health conditions and mental health. We have observed people can be treated differently depending upon your race, your ethnic background, and ability to pay. So we invited everyone from the medical district to come to the equity forum to learn more about disparities, to learn about what they can do. So definitely health education. You can't, giving people that information is a big first start, and that's where it starts. So here's an area that was categorized under health system integration, and Reese offers us this quote. They've asked chaplains to come and partner with them and be a partner to work with the social determinants of health wheel. And some of you, if you've used Epic as one of the vendors for electronic health records, probably the largest in the country, if you've used that, that's a feature. Back to the quote, whenever somebody comes up as high risk in any one of the domains, then they have gone out and surveyed, found over 40 different partners in the community that identified being able to support any one of those domains. So a rich sort of investment into what that means in the record. So that's the more common. And then here we kind of start to veer a little bit toward what's common. Just gotta move this. David offers, we spend half of one day in small group setting discussing our opinions and thoughts about suicide, and we do it in a very non-threatening way. But you get people really thinking about it, why it's hard for me to discuss this, what are my hangups. So a suicide interventional program to work toward preventing that, and something that was a little bit more on the common side of our coding. Next slide, please. And Kelsey, jump on in here if you want a little more, I don't know, and flesh this a little bit, that kind of thing.
I will just say, as you can see from some of the quotes that Paul's reading, like it is, so these are people that we interviewed, and they're telling us about, when we asked, ways in which they're promoting community health. And they're so important, all of these things, but they're not as directly tied to community health and population health as one who I think from outside chaplaincy would expect to see. So it's just, I mean, I am a chaplain, but speaking based on my experience with my public health colleagues, like it's just not, I don't know that would be what we would anticipate seeing. So yeah, just fascinating.
It was fascinating. I agree. Man, and this is something we talked about during our meetings. It's inspiring to hear how chaplains are doing work, certainly at the bedside or chairside, but beyond that, and what does that really mean in a more systemic rippling effect kind of way? So a little less common. A couple of slides here for this. This faith community nursing, or some of the old language was a parish nursing model, as it's referred to here from Taylor. It started as parish nursing, and feel like that started maybe in the Pacific Northwest state this person was in, but we've had what was the parish nursing program. And now they're calling it faith community nursing. Probably a little over 20 years ago, I think, here in our state. What they do is they do a lot of things, but they offer a training. Basically, the idea is to equip nurses who are part of churches or other faith communities to help be able to offer nursing ministry within the context of their churches. I've been involved with some of the training they've done around prayer and around appropriate spiritual care, recognizing that not everybody may believe exactly the thing that you do, even if they're in your congregation, and helping them understand the difference between spirituality and religion, having healthy boundaries, knowing when to ask for help. And then focusing a little bit more on community social networks. That was an area I appreciate you highlighting. I like the way you broke that down, by the way, Kelsey, too. And this is from Carrie. The goal of the organization is to match patients that are primary care and sometimes inpatient providers have identified as older, characterized as 50 years of age or older. That hurts a little bit. And either lonely or isolated with a chronic illness, with a companion from a local religious congregation. The goal is to help reduce social isolation, loneliness, and ultimately to connect that patient with a meaningful community or set of supports of their own that they identify. It's kind of cool, I get behind that. Carrie goes on, a secondary goal of the program is to connect community members with resources as the connector learns that the companion has food insecurity issues, behavioral health issues, transportation issues, or other social determinants of health. The key is to identify and refer that person on. We have one more slide to kind of highlight these rich descriptions of less common results. Just two more. And one is these community health needs assessments. This is a little bit lower on the graph that Kelsey featured. So the three of us, again, this is from Suzanne. The chaplain, a health system in a neighboring community, and the health department would meet. The health department had the responsibility of getting a community health needs assessment questionnaire, a survey out to the entire community. Those results would come in and be tabulated. So I would have the responsibility of taking that information, the results of the community health needs assessment, and search for other resources, as well as to write the report for the medical center. And then from Tiffany. Within our community, we have a lot of people who have experienced scarcity in their life. And so a lot of them truly only come with their memories. And so this existential crisis was, quote, I'm losing those last things I have in my life, end quote. The priority was capturing memories in a book in a tangible physical form. That was a really cool program, by the way. Loved reading about this one as well, Kelsey. I think that's what we got for our quotes. So thanks to our colleagues as participants who offered that really important data to us.
And there's a lot more details that we could kind of highlight with regards to these less common programs that are just fascinating, as Paul mentioned. Tiffany and her center, the program, I mean, the quote couldn't actually do justice to the program that Tiffany described, where both community members and individuals using the point of health delivery were working together to be able to create this book. And she inadvertently created a community for the volunteers from the community, and how that ended up really playing a huge role in community members' sense of meaning and purpose in their lives. And just some fascinating things. And that, as Paul says, we're really indebted to those participants. But as you can see, and we noted, like it's a little tangential to what we typically think about in terms of impacting health outcomes and patient health outcomes. So let me give you a little bit of a summary here of what Paul and I just kind of ran through pretty quickly, and kind of before we move into the discussion. So again, this project, we really focused on exploring how chaplains are involved in community health and population health. We used an explanatory sequential mixed methods approach. And what we saw were that chaplains are primarily focused on efforts that address inequities within the social determinants, specifically problems with healthcare access and quality, and that social and community context and needs within that arena. Their interventions were really focused on, most commonly on health education and system integration. However, there were some very innovative and select unique programs that were both measuring their impact as well as using unique avenues to really support the community members and so on. And then most of the interventions, as we mentioned before, really focused on this social health area of need. So how do we make sense out of all this? Well, when we think about chaplains' attention and how we are integrated and how we're providing care right now within healthcare, so there is some growing energy around shifting towards outpatient and cross-continuum care. There's been a lot of energy and a lot of conversation around telechaplaincy and how to make that not only feasible, but different skills in which individuals need to be able to provide chaplaincy care in that way. So it makes sense that there may be some growing energy in that way around community wellness and community health. I also noticed that I was actually surprised to see as much effort and energy focused on the healthcare access and quality side of the social determinants. But I think there's literature that supports this growing interest by chaplains in the profession that, and based on the research that's come out about chaplains actually playing a role in patient experience, and perhaps the flexibility within chaplains' responsibilities and roles really allows for chaplains to devote energy more towards that healthcare access and quality, which in patient experience falls right in that. And then the emphasis on social health, beyond the fact that the spiritual and existential aspects of what we do is important to one's social identity as well as mental and physical identity. It was exciting to see that the chaplains are really kind of spearheading a lot of those efforts, and that alignment with the recent report by the Surgeon General that loneliness is really this epidemic and major issue for health and health outcomes within the United States was exciting to see. And that perhaps chaplains' emphasis there, beyond the fact that that's kind of our arena of expertise, is exciting to see from my perspective. Now, I'm going to move on to, now, this is kind of a big question, and some of our respondents talked about this, some more directly than others. But is community health programs, are these outreach in the ways in which chaplains are integrated in health systems? Is it really part of chaplains' scope of practice and their expertise? So this whole slide is really questions for us to consider, and I would love to hear your all's thoughts on it. Is it part of our job? We had one participant who very directly said, you know, I have no idea why, as a chaplain, I was tasked with that. That's not in my background. It's not in my training. It's not in my field of expertise. And so I think there's some mix as to whether or not this is the responsibility of a chaplain. And if we were to hypothetically kind of talk through that, let's say it is. This is part of who chaplains are and how chaplains should help promote health and well-being in the community. And then questions that are raised, I think for us is, you know, there's probably a gap in chaplaincy education, and could that lack of education on whether it be public health, population health, social determinants, even at the most basic level, could that lack of training or even measuring impact, could that hinder our success? And how do we make the case or attend to those issues based on the workload and the efforts that we currently hold? Who pays for us to do that? Or is it just that the more affluent systems who have more chaplains can allow for chaplains to be more engaged in wider ways? How is that going to work out? What does that mean for us as a profession? Then on the other side, if we were to say, you know what, no, this stuff is not within the scope of expertise. It doesn't matter that, you know, chaplains or religious communities have historically played a very active role in promoting health in the community. That's okay. But right now, what chaplains are strictly experts within a specific sector or setting. It makes me think more about the wider societal impact. So could social and spiritual support within communities disappear, especially as we have a changing religious kind of environment in the United States, is specifically what I'm thinking of. As religious communities kind of wane in their attendance and their energy, how could that change? Should chaplains with different training take on those efforts? So should we make sure that there's a pathway to create chaplaincy opportunities for people who specialize in, you know, whether it be movement chaplaincy, and bring that more mainstream and have, you know, like, what does that mean for chaplains and what their expertise are? Do we need different titles for chaplains based on how they're engaging and in what ways? And I know some of these questions may seem very, very focused, but I think there's a lot of implications when we talk about community level and population level in large shifts in systems that have to be considered as well. I also wonder about, what does it mean for chaplains to engage and participate in the restructuring of the U.S. health system? So as a health system incentivizes outpatient preventative care, you know, what is our chaplain's role? Where do we engage with that, or do we not? And if we're going to claim that spiritual health is a core to whole person health, then how do we, as a profession and as even in our day-to-day jobs as a chaplain, engage with those aspects of the healthcare system? And could that mean that more community clergy with limited understanding of the health system actually step into that place? So all of these implications, I think, were kind of raised for me. The biggest kind of area that I wondered is, you know, chaplains are out there jumping in with all their energy, with all their might to really promote community health in the way that both that they're driven by their own passion, as well as in ways that the health system has like identified gaps and things that really put the patient and the families and the communities first. But what does that mean for, you know, the chaplain students I work with? What do I need to make sure that they have and are equipped with in leaving the residency or the chaplain program they're in to moving into a community hospital? What skills do I need to make sure they have? And at the same time, maybe I need to focus on different things. There's a lot of questions, but I think that for me, the educational piece really kind of was something I focused on. Now, I also want to raise up that our study was not able, I'm sure, to get all of the things out there that exist in the ways in which chaplains are really addressing kind of the social inequities and the ways in which systems are kind of hindering health for all populations and all communities. If you look here on the left, I've got a article I clipped from, well, actually Paul found, sent to me, I clipped on LinkedIn about Desmond Hayes in Texas, who really helped do a food drive to address some food insecurity as part of, didn't do that. You know, we just got to keep these webinars spicy, like throw confetti every once in a while. That is just fascinating that he jumped in and really is, as a chaplain, having some really unique skills to be able to help address food insecurity and to really lead those efforts. So we know that we didn't capture all the ways in which chaplains are really engaging at population level, community level to promote health and wellness. And I really do think that there's something there about chaplain skills and abilities to do that. And, you know, I kind of raised is it our responsibility? Is it our role? Is it within our field house of expertise question? And, you know, I think regardless of what we think, there are places that are going to push for chaplaincy involvement, whether one way or the other, that we like it or not, and how they integrate. So Equality Health, you'll have to look at their website. They're actually a provider, meaning a healthcare payer, a provider, or not a healthcare payer. They're a provider. They're like a healthcare service, appointed delivery, delivering at-home care, who have decided they're integrating chaplains on their team. This article was actually published in June of last year. And they decided with that they're going to include chaplains. Oops, wrong way. Just got excited there. And then you also have I'm sure you all have all heard about the conversation in Texas about integrating chaplains on public school campuses. And I know that there are people perhaps who are on this call that are from Texas. Many chaplains actually signed a bill against it. But will the wider community start determining what chaplains and who chaplains are and their scope of responsibilities before we can? I don't know. That's kind of where these two articles kind of raise that question for me. And then you've also got, I think at the same time, United Healthcare which is a health insurance company, creating a spiritual support program, outpatient wise, to help promote spiritual support. So what does all of this mean? In as much as technically chaplains are probably pretty overloaded as it is, but there are really good skills that chaplains have to be able to make these things reality and promote them. Really quick, let me just say some of our limitations of the study and then jump into questions so that you guys can ask those. So we do have some response bias. We didn't ask the healthcare administrators or other representatives to actually share their perspectives on chaplains' involvement. This was all via chaplain, so there's the chance that there's some response bias there, as well as based on our invitation to participate in the survey and how that went out. We do have a small sample size, although I will say there's an article that talked about the number of programs hospitals were offering. It was published, I think, in Health Affairs. Our number was not too different, although I don't think we obviously identified the same number of programs. But the small sample size and kind of the vague descriptions kind of can challenge how we analyzed it. And then there's obviously the opportunity for reporting errors, no matter who the participant is. But we noticed, and I didn't go into that detail today, but a large percentage of the chaplains who participated reported working for a Protestant operated hospital. But as somebody who's done a lot of research on hospital characteristics and chaplains, there aren't that many Protestant operated hospitals. So I think there may be some either gaps in chaplain understanding of what a religiously operated hospital is, or just some reporting errors that could occur. All right, and with that, I will take us to questions. And Paul can jump back on to.
Yeah, some friends of mine are kindly offering questions. I'll start with a friend of ours, Kelsey, John Betts. Thank you, John, for tuning in, number one, to our webinar, and I also appreciate you offering this question. John writes, did the study also look at how military chaplains are trained to conduct religious leader engagement to help with connecting and assisting the needs of local populations where the military finds themselves?
Oh, that's great, John. No, the study did not specifically ask about that. I can say that we did have, the sample does represent military chaplains. However, that specific approach to gathering information was not included. And that again adds us, I think, a really important consideration is that depending on the employing organization, there may be different things that are just naturally a part of the role, as John mentions with regards to military chaplains. So a great point. Thank you, John.
Yeah, thanks, John. And then a friend of mine from Minnesota, we both used to work in a healthcare system called mHealth Fairview, and she writes about a story. Thank you, Carolyn, for offering this. It's not so much a question as it is a comment, and I'm just going to read, Carolyn, what you offered us. And it has I'll say to you, Kelsey, and to all of us, it has a religious specific public health engagement kind of feel to it, which I think that came up a little bit in our data, but I'll just go ahead and read it. Thanks, Carolyn. One awesome recent example of chaplain's role in community health, this fatwa on donor breast milk recently announced here in Minnesota, unfortunately not included in our coverage, but our colleague and former lead Muslim chaplain Tamara Abdelaziz played an integral role in facilitating connection and relationship between physicians and community leaders so that they could work to develop this fatwa. So she also references, in case some of you are interested, a Minnesota Public Radio news story. You can type in words like Minnesota Muslim women and you'll get there. Thank you, Carolyn. And then a question, go ahead.
That is awesome, amazing to hear about. And that's what I think is also a challenge with doing research on this specific topic. As I mentioned, like most of these programs were very local in origins, and most really effective, I think, population health efforts are really focused on a specific community and a specific need. And so going from one place to another, it doesn't make sense to make a comparison from a community in Minnesota to a community in Alabama based on the needs of the people and the health challenges and the system issues that are at play, which is both a blessing that we can, adjust interventions and things as the context demands. But when we think about doing research on it, it makes it that much more complex. And that much more nuanced.
Agreed. All right, I'm going to keep rolling here, Kelsey. Patricia, thank you for your question. And she writes, were nursing homes and independent living, were they in these studies?
So we do have most of the, I'm trying to recall, so we had 44% were hospital, 44% were a health system, and then we did have representation from healthcare I have to be careful with my specifics so that I'm not I'm keeping all the participants anonymous, but a long-term care or a skilled nursing facility represented.
Thank you for the question, Patricia. Samuel, I'm seeing your question here. It feels very specific to transforming chaplaincy. We'd love to hear from you. If you could reach out to us through our general website stuff, please do that. Appreciate your question, your research interests, and what you're exploring. Very cool. Jay, you have a great question about the slides. Are they going to be available? if you want to speak to that, Kelsey, I know these go on YouTube, these presentations, and
Yeah, they're going to go on YouTube, Jay. We are in the process of finalizing the first manuscript. There will be 2 manuscripts. We will make sure that Transforming Chaplaincy readily announces when those are available. Jay, reach out to me if you have any other questions.
cool. I think just some good vibes here. Thanks everybody for your tuning in. I'm not seeing any other questions. We have a few more minutes. Kelsey, I know you and I have talked a lot about these data and their implications, and I'm happy to talk a little bit more. But friends, we are tuning in here in case you have some additional questions. But again, appreciate the good vibes. And I'm just lucky I got to join you, Kelsey, in this. Like I wasn't beating the drum on this issue. In fact, to you, Kelsey, I've said this many times, and this is a great response to you tuning in, because I didn't know a whole lot about this when I was trained in chaplaincy. And when I kind of came up, and I still remember the first time I remember hearing about community benefit reporting, and I looked like a cow looking at a new gate, and I just was kind of baffled. And so it's been fun for me to get into these data some more and hear about some really important work that's happening. Okay. So Catherine, thank you for your question. Another friend, I'm thinking of how social work and chaplaincy have crossover and interconnections in their arenas. I wonder about that in relating to, sorry, I got to open this up a little bit further. I'm not seeing that, but I think that question maybe tees it up enough. Kelsey, you have any thoughts?
Yeah, I would say the one thing that we did hear from the participants is that key to these successful programs was collaboration. It wasn't a matter of one profession claiming expertise over another or any type of competitive environment for effective programs, but rather all of these all of the chaplains we interviewed spoke very specifically to the need that everybody was on the same page, that sometimes chaplains wear different hats, sometimes all professions wear different hats, but it is a collaborative approach. We didn't talk much about the educational aspect and training for chaplains with regards to interdisciplinary training, but I could see where that would be advantageous in really promoting more collaborative work environment moving forward. At the same juncture, not just collaboration or crossover training or interdisciplinary training for chaplains, but making sure that is something that's accessible for individuals across health professions. That when you learn early that the people in other disciplines are on your team and you're working together to achieve the same outcome, and that being the well-being and the health of patients, families, and communities, then it makes going into professional environment that much easier to collaborate and knowing who is there to support you.
Kelsey, to that end, the first additional feature beyond our data that we showed was from Desmond Hay, the chaplain there. And Desmond has a master's of public health, and so has had a focus and has learned some additional skills beyond our core chaplaincy training. And this has been an interesting sort of, I don't know if you have a sense, like how could we as a profession, like what does that mean to look beyond the bedside or incorporating this as part of the bedside? Because if you're not at the bedside, where are you then doing your work?
Yeah, and I think there are some chaplains who probably very naturally have the skills to be able to design and implement a program, whether it be because they had a previous career that equipped them to do that, or they're just natural in those skills of organizing, delivering, and engaging with the community. Maybe that's natural. But I do think that there is definitely space to be able to provide more resources and tools for individuals either moving into chaplaincy or currently in chaplaincy to be able to engage the community in that way. And some people are good for it, meaning they've got the skills and the natural interest, and some people aren't, and that's okay. But it's a conversation that I think is warranted.
Well, and I'm glad we had this conversation. It's 1 o'clock. We're at the top of the hour. Friends, thank you for joining us. As somebody who gets a paycheck from Transforming Chaplaincy, I am very grateful for your support. Check out our website. We've got webinars coming up. If you're not signed up for our newsletter, go to the top right of that website and please drop your email address in there. We'd love to be in touch. And thanks for your questions. Thanks for your engagement. Keep doing what you're doing. Kelsey, any final words from you?
Thank you.
All right. All right, friends. Thanks.
Thanks, everybody.